See if my microphone is on. Yes, good evening, everyone. Please do come in and join us for the last session of the day, Universities and the Public Health System. How can they do better together? So our objective in this session is to pose some challenging questions about the organization of public health and the kinds of competencies that are needed for it to carry out its performance better in a world where we've already recently experienced significant public health crisis in the form of the COVID-19 pandemic, a communicable disease crisis. But let us acknowledge that that's not the only public health crisis that we are facing in many parts of the world. We've had other sessions in this meeting talking about non-communicable diseases. We know that there are mental health and substance use crises in many environments. And of course, we have climate change imposing all kinds of conditions on different parts of the world. So let's think about the demands on public health, not only in relation to a crisis like the pandemic, but also we need to be honest and modest about the competence and capabilities of public health and what it can do. So my name is Peter Berman. I am a adjunct professor at Harvard School of Public Health and professor emeritus at the School of Population and Public Health at the University of British Columbia. And I'm going to lead us off today. We have three other speakers. Unfortunately, one of them was not able to be with us in person, but he is available to be with us on a video, which you will see shortly. That's Dr. Zabir Hassan from Johns Hopkins. We have Dr. Bhakti Ansoti, also from Johns Hopkins, and Dr. Hailu Dufera from Harvard, also here. I would also like to apologize. We had a discussant with us from WHO for this session, but unfortunately she also could not make it due to some of the reasons we've all been talking about for the last day and will continue to talk about. Okay, my talk is about the public health system. What is it? What does it do? And what competencies does it need to do what it needs to do better? And I'll start with this question of what is meant by the public health system. We see this term utilized quite a lot in the literature, but it's often not very carefully defined. We started to think globally about health systems largely driven by the year 2000 World Health Report, in which WHO defined the health system as all the activities whose primary purpose is to promote, restore, or maintain health. And they further elaborated this definition with the statement that beyond the boundaries of this definition are those activities whose primary purpose is something other than health, education, for example, even if those activities have a secondary health-enhancing benefit. So we should think about this as helpful in defining the public health system. Could we define the public health system then as the people and organizations whose primary purpose is to carry out public health functions? And we should be very clear, and a little bit of hygiene in our terminology use is important. I don't know how many of you know that WHO has a department of terminological hygiene. This is not the same as the government health system, the public health system. Many countries call their government health systems the public health system. The term public can be confusing, and it should not be synonymous with WHO's definition of the whole health system, because that's not very practical. If the public health system is everything in the whole health system, then we shouldn't be talking about this subject today. We should just be talking about what is the health system. So let's dig in a little further. Why do we need to answer this question? Well, firstly, if we want to invest in and develop the capacities to carry out public health functions, we need to know who's doing what. And we need to be able to monitor that in order to finance it, to manage it more effectively, and evaluate its performance. So this is a pretty important question. Do we have a definition of public health functions that can be rigorously and practically applied to the people and organizations who are doing them? And can we agree on some boundaries for that definition, analogous to that concept of primary purpose? And I think this is a really critical set of questions to address if we're going to think about how to build up public health capacities. So if you want to define public health as a domain of action, we confront some challenges. A recent paper by Scott Greer from the University of Michigan gave the opinion that public health, the term public health, often suffers from misplaced concreteness because it's used to refer to many different things. It's used to refer to a different set of activities, to different actors, even perspectives. We talk about the public health view or the public health attitude or whatever. We talk about institutions, and I want to point out another terminological hygiene point, that we should use the term organizations clearly and not always use institutions to mean organizations. Institutions can mean something different, as you'll see in a moment, and functions. So I recommend, if you're interested in this, consulting this volume where this paper appears. It's available for free download from World Scientific Publications. And here's an example. This is a chart that appeared in 2021 from the Public Health Agency of Canada to define the public health system of Canada. And you can see that in the middle, it refers to public health institutions, and then around it are all these other organizations, including some that are in the government and some that are professional, other government departments, private sector and industry, and so on. So is all of this the public health system of Canada? Very ambitious. Should we really be asking the question of how to operate this public health system of Canada if it looks like this? I think this is an example of that kind of overly inclusive thinking about what might be a practical way of thinking about the public health system. So WHO recently and for many years has been talking about something called essential public health functions. How helpful are those for defining the public health system? This is a recent WHO publication on this topic. If you go back into the literature, you'll find 10 or 15 different versions of essential public health functions from different countries, different regional offices, different international organizations, and so on. But let's look at this one in a little more detail. These are the 12 essential public health functions in the more recent WHO publication. And I want to point out some of these that we would consider to be very much core, the public health surveillance and monitoring, right? But I want to point out others that are really quite ambitious, like health service quality and equity. Are the public health organizations responsible for health service quality in the whole healthcare system? I think that's very ambitious. Or health promotion. Well, some of this could be done by public health organizations, but a lot of it is done in the physician-patient encounter in clinical care. And so if we go through these essential public health functions, I think we will see that it's quite a lot to ask a defined set of public health organizations to carry out all of these essential public health functions. And if we persist in that approach, we may end up with an overly comprehensive agenda that cannot be effectively implemented by the organizations that are asked to do so. So let's look at this from an organizational analysis perspective. If we adopt too broad a notion of the essential public health functions, we come up with a definition of public health system which is close to the whole health system, not very practical. I think we need to acknowledge that the public health organizations and the people who work in those organizations don't carry out the actions for all the essential public health functions. Sorry, I went too far. They do some of them, but they study many of them, and they advise others to do the things that result from their studies and their recommendations, right? So the competencies that may be needed are to do certain things, to study certain things, and to advise and promote certain things. And those are not the same competencies. They're rather different. I would argue that we've been focusing on an incomplete set of competencies for successful public health organizations. And this may be different in different jurisdictions because the organizations that make up the public health system are very different in different jurisdictions. So I put together a preliminary visualization of how this might look, and we might think about something we might call the core public health system, which has a set of core functions, things that it does. Maybe, and this is just a proposal, health and disease monitoring and surveillance, outbreak response, behavior change communications, community-focused monitoring, guidance and advice to other organizations. And then these other types of organizations exist in the ecosystem, and these are the places where the public health organizations do studies and provide advice. And public health system organizations need to have the competencies to do both. Do things, study things, and provide advice. This appears in a paper you see cited below, and although the next video presentation will, to my surprise, plug this publication, if you're interested, there is a brochure in the back on the table where the video camera is, and you can pick one up and gain more information on the contents on your way out. So when we think about how do we apply these ideas, the pandemic is an interesting example, recent history, which gives us a very insightful example of how we might think about these things. What were the people and organizations of the public health system during the pandemic, and how did they act? And it's quite different if we look at large federal states like the United States or Canada, where state-level organizations exist and are often quite autonomous from the national organizations like the US CDC or the Public Health Agency of Canada. And in other countries, in smaller states and so on, we might see very different patterns where these functions are much more integrated. And in some cases, such as the Nordic countries, they're quite integrated with the clinical medical care system as well. But that is not true in the United States and in many other countries. So what can we learn from studying the organization of the public health system? What are the advantages and disadvantages of different organizational models? And today, this is quite a timely topic, as we'll hear in a minute, because the world is investing in new national public health institutes all around the world. These are public health system organizations. Where do they sit? To whom do they report? What are their responsibilities? What are the different ways of organizing these things? These are critical questions for future preparedness, both for communicable disease crisis, but also for other public health crises. So WHO, it's interesting, produced a manual some years ago to try to map organizational design. This looks not only at the typical organogram type of approach, which shows boxes and lines, but they call this the organograph method, where these lines also show authorities, responsibilities, and who controls what, and so on. And I think this is the kind of analysis we might need to do more of to understand how public health systems are actually organized and how well they work. We developed some of this work in the context of research we did using something we call the IPOG framework for institutions, not organizations, institutions, politics, the organization of the public health system, and governance as shown here as the place where political structures and organizational structures interact to produce decisions for action in the face of a crisis. And I'm not going to go into this any further right now in my presentation. So let me just conclude that organizational analysis of the public health system, I think, should be and can be a rich area of investigation for public health students. Think about a large federal country like India, where the states have a great deal of independent responsibility for organizing to address health. What's the difference across states in a place like India or in the United States or in Russia, for example, about the public health structures? And we need to think about this not only in terms of a crisis like COVID-19, a communicable disease crisis, but emerging pandemics that are affecting the world. Then I think the question that comes up is, are we training the public health professionals and the competencies for these organizations in the right areas sufficiently to be able to carry out some of these other functions that include advising others, the policy process, communication with the public, and so on. So I would argue that this is an area that is quite relevant for the future of public health broadly, and also for the development of these new national public health institutes. And in a moment, we will hear more about that from Bhakti, one of our speakers. So that's by way of introduction. And now I'd like to ask John if he would put on the video for our colleague Zabir Hassan to talk about the recent experience in Bangladesh during the pandemic.
Hassan. I'm an assistant scientist in the Bloomberg School of Public Health in the Department of International Health. And my work mostly revolves around health policy and system research and health system governance. And as part of that work, we did look into the COVID-19 response in Bangladesh. And here I really want to thank our collaborator from James P. Grant School of Public Health in Dhaka, Bangladesh. Without their support, this case study was not possible. So let's take you back in March 2020, when the entire world was stopped to implement a social distancing policy to reduce the spread of COVID-19 pandemic. And in Bangladesh, the government took a very unique approach, calling it as a public holiday. The reason why they did it because they don't want to create a panic among people. But it ended up doing a totally different unintended consequence. So almost 11 million people within Dhaka, which is the capital city, went out of the city to their home. This mass exodus actually created a significant COVID-19 spread from where it was a few hundred clusters of cases to a countrywide epidemic. So if we look at different countries across the world and how they performed to contain the COVID-19, there was a significant variation. Even if you take away the capacity of the health system, the resource available for the health system, only the governance processes led to a significant variation. And that was the question we were asking during emergency, how government make those policy decisions. So we implemented multiple case studies across the country. Our team did it, and in Bangladesh, we implemented the case study. These studies were published as a book, and also we published a significant number of peer review articles, which you can access. So all of these case studies were led by this IPOG framework, and I believe other speakers are already talked about it, but the institution, policy, and organizational factor, which we are addressing as upstream factors, affects policy implementation, which we defined as the governance processes. And those processes influence the interventions, their timing, stringency, robustness, and the implementation process. And of course, all of these ended up creating a varying degree of outcome that can be health-related or non-health related. And all of these are actually happening when there is a bigger contextual background related to the country's culture, societal values, how the leaders and decision makers are working with the citizens and the communities. So we took a convergent parallel design as a mixed method approach, where 5 streams of data were interconnected together, and we tried to integrate all the finding together, taking a systems thinking lens. And I will talk about it later. And in the next few slides, I will talk about what are the different streams of data looks like. So first, we looked into the number of policies implemented by the government. Almost 500, more than 500 different small to bigger policies were implemented within the first 6 months of COVID-19 pandemic in Bangladesh. And there are different levels of the policy. You can see here, if you think about those policies were targeted to any kind of a subpopulation or total population, the complexity of the policy, the enforcement is done with the law enforcement, without the law enforcement, if it is voluntary, or there is a legal penalty or fine associated with that. And when we provided those attributes for each those policy, we identified which of the policies were more complex and required significant investment from the government. And of course, one of those significant policies were declaration of the emergency. And then when we have the list of the policy, we map them out across the timeline, COVID-19 timeline, and the number of cases and number of deaths. And that actually allowed us to identify how different policies were clustered in different time frame, and what are the causation, almost like a cause and effect type of a relationship across the different policy implementation. We looked into the formal and informal relationships of the government structure within the context of COVID and even before the COVID. So this is the organizational diagram of public health sector in Bangladesh, which involves both public health and the health service delivery system. So you can see here on top, we have the Prime Minister office and the two ministries, Ministry of Health and Ministry of Home, Ministry of Local Government, who are mostly in charge of a lot of service delivery. And we have this other host of government, non-government and international organization, and there are some loose connection between them, but there are a lot of verticals. But when COVID-19 started, we can see a lot of other ministries like Ministry of Foreign Affairs, Ministry of Disaster Management, Armed Forces, everyone came together. And while those kind of a higher level cabinet division were created to build consensus on how those policies being formulated, government also pulled a lot of non-government organization and international technical support to bring everyone together. So there was a significant formalized collaboration that was happening, but at the higher level, but also at the lower level, at the district level, there are different coordination committee that created zonal lockdown or zonal social distancing policy regulation. But what we identified, there is also a lot of informal communication that was happening, because through the formal structure, when you try to implement those policy, things doesn't move that fast. So a lot of the leaders of different organizations were creating those kind of informal channel of communication that sometimes helped to push forward the policy faster, but also sometimes created parallel channel of communication that creating some kind of a coordination mismanagement. We did an extensive literature review, both peer-reviewed and non-peer-reviewed gray literature, and identified 64 articles which actually talked about how this COVID-19 response was implemented across the country. And we did key informant interview where the government representative talked about why those words is being used as a public holiday rather than lockdown or shutdown to reduce panic. They were talking about good coordination at the central and the decentralized level at the district level, and how they morphed across the timeline, initially with a really good coordination, but then the fatigue came through and those coordination deteriorated. They talked about the cabinet division taking a significant role, but also how the role of IDCR, which is the premier organization pushing forward the public health agenda, which is very similar to a CDC in Bangladesh and the Director General of Health Service, how there is a tension between those two leading organizations, but also how beyond the public sector, private sector were lobbying against those lockdown and the shutdown policy because they are trying to balance between the economy and the pandemic response. So while the significant challenge that we face that we have this 5 different stream of information, and when we are everything bringing together, not everything was fitting correctly because different stakeholder has a different narrative. Somebody is saying everything is rosy, everything is going fine, but then again the peer-reviewed literature was saying that not everything was as good as it seems. So one of the main reasons was not all the data sources and the stakeholder has the visibility of the entire ecosystem of the COVID-19 response and how single decision can lead to the second or third degree of impact. And at the end of the day, we have to ground all the evidence within the reality because that is the most important thing. We really need to understand how those policies were implemented within the context of the country. So how can we make sense of all of this information? We used puzzle loop diagram, which is a soft system approach. Here we are basically identifying important variables across the system and trying to link them with the positive or negative causal link. And there can be delayed within the link. So think about if the number of patients who are testing for COVID-19, that can significantly increase the health worker payment and incentive, but that takes a long time. Where the number of stocks, if that increases, that also increases the ability to health worker to provide the services, but that is almost like an immediate effect. So we can identify a lot of positive or negative feedback loops and also identify leverage points, which actually significantly change the ecosystem of COVID-19 response. So we did that and we found out a lot of variables related to IPOG factors and we create this complex map. And it was really difficult to explain how things are going forward using this map. So in brief, we identify 4 broader subdomain or subsystem. One is related to the disease transmission. One is related to the impact of micro and the macroeconomy, disease surveillance, use of evidence, and health system governance, another domain that we have found out. And we also found out politics, information, and communication dynamics, which I will dive a little bit into in the next few slides because I started with the public holiday story. So hopefully this is a little bit more better visualization. And you can see here there are a lot of IPOG factors labeled across different colors and positive and negative link. And what we have identified 3 very important positive feedback loop. So unregulated political rhetoric and political instability has this vicious positive feedback loop because increasing political rhetoric, which is unregulated, increases political instability and vice versa. The other positive feedback loop linked with the 2 negative linkage are communication strategy and misinformation. So while these are balancing increased communication strategy effectiveness, actually reduce misinformation, then again, the increased misinformation is reducing the effect of effective communication. So there is this kind of a balancing act going on. And across these 4 variables, we can see how communication governance is being implemented and regulated. But all of these 4 variables are also linked with multiple other variables like lobbying for businesses, religious leaders who are in favor of regulation, then again, who are not in favor of regulation. And then again, public confidence, trust, stigma around COVID-19, all of them are making this subdomain of a broader system complex. So even if this subdomain, if it is this much complex. The entire COVID-19 ecosystem is much, much more complex. So if we take a step back, what we can identify, there are four bigger learning. One is public trust, misinformation, and low scientific literacy were significantly shaping the messaging and response. Inconsistent messaging from religious groups, social media, and uncoordinated um, agencies fueling misinformation, and that was significantly affecting the COVID-19 response. But then again, there are volunteers and journalists who are pursuing to combat the misinformation that was actually creating a balance. Social media ecosystem was reinforcing distrust and restricting government's action. And that was one of the biggest reasons why the centralized decision making for the COVID-19 response was not working, because when everything when all the power and the channel of communication is being centralized, at the decentralized or new media, just like WhatsApp group and Facebook forums, those cannot be regulated when you don't have enough decentralized regulatory power. So what we ended up finding out, it is complex when institutional politics and organization comes together, and small changes in the governance process can lead to significant shift in public behavior and pandemic response. And early decision actually sets path on how later, as I mentioned, second and third degree impact happens in 2, 3, 4 months away. So it's necessary to align public health function with the dynamic needs of the public health emergencies, and coordinated and transparent communication, inclusive planning, decentralized capacity building, and engagement with diverse stakeholders is very, very much important. It is most important to build trust in the system, which is very complex, and from the perspective of the population, it's very opaque how the system is working. It's very difficult to convince them the system is working, because from their perspective, they might see that things are not improving. But a stable equilibrium is also a sign that the system is functioning, not making things worse. So I think communication is much, much important, and we need to focus on that. So thank you so much, everyone. I know I'm not there in person, so I will not be able to answer your question directly, but Dr. Peter Berman and others are there who can share more information about that. And if you have any burning question, feel free to contact me in this email address, and my social media handle is also there. So thank you so much, and I really appreciate for your time today. Thank you.
Our thanks to Zabir, and now Dr. Bhakti Hansoti will
take over. Thank you so
present to
much.
us. Thank you.
So I think I know a lot of you in the room, and for those of you who know me as my day job, I'm an emergency physician, implementation scientist, thanks to Dr. Peters over there, who inspired my career like 15 years ago. But during all my research internationally, I developed this deep-founded interest in how do you build capacity, like everybody else in the room. So March 2020, I was pregnant, I had COVID-19, I was housebound for a month on oxygen, which is the perfect way to write a grant. So the grant that I wrote was this one with Dr. Sarah Bennett, which was strengthening public health institutions and applying organizational management principles. Everything I'm going to talk to you about today is freely available. My email will be available at the end of this. I want you to take the tools, use the tools, apply them to the public health organizations that you're working with. We've been so grateful to do this work, and it's been eye-opening for us. And as we heard from our previous speakers, we need coordinated response, we need communication, we need public health systems and institutions that can withstand the storm, right? I think that's what's been hard for a lot of us this last couple of weeks, is how vulnerable we feel, right? How easy it was to knock down the house of cards. And I think some of what we'll discuss today perhaps makes the institutions that we're so reliant on a little bit more resilient. So I'm going to talk about the National Public Health Institutes. That was the focus of our work. There's a big team of us. John, I don't know if there's a way to fix the cutting of the top of the slides. But my co-principal investigator is Dr. Sarah Bennett, who is in the Department of International Health at School of Public Health and a professor of health systems. A lot of the critical thinking really comes from my colleague, Cyrus Engineer, who is an expert in this space, having been a previous Baldrige investigator and have come from the healthcare industry and healthcare industry excellence. And we have a whole host of wonderful research staff who have helped us build this work together. So what is a National Public Health Institute? Well, a Public Health Institute, broadly defined, can be a government agency or a closely networked group of agencies that provides scientific leadership, expertise, and coordination of public health activities. And they are established in over 100 countries. So if you're a visual person like me, CDC in Atlanta is our National Public Health Institute, right? In countries like Colombia and Finland that have been around for decades. In other countries, such as Liberia, it was the Ebola epidemic that really spurred the creation of the National Public Health Institute. And although the exact governance and structure of these institutions often vary, the functions are often overlapping, right? Public health response and improving health security. So one of the things we heard, right, we heard this in Zabira's talk and Dr. Berman's talk, is that when all of these functions are happening in different places, different spaces, different biases, different teams, there's a lack of a coordinated response. But for a cohesive public health strategy to execute on those public health functions, you need a coordinated strategic and organizational response. And that's where MPHIs play a really key role and are central, I think, for our future pandemic preparedness, but also maintaining essential public health functions. But there are vulnerabilities, right? So a lot of the NPHIs are reliant on donor funding. They're potentially even embedded in the Ministry of Health. So in the last couple of years, I have worked with several teams of NPHI leaders because when the government changes, the leaders change, right? Often the workforce is comprised of scientific experts. So my colleague who's deputy director at Liberia, he was my medical student at JFK, probably around 2010, right, just before Ebola. And then Ebola happened, and he was raised, promoted. Now he's deputy director of his organization. And it's very different to being a physician, right? And they tend to be really formed during public health crisis and emergency, and then we kind of forget about them, right, during preparedness. So the goal of our project was to apply organizational strengthening interventions to strengthen NPHIs using evidence-based conceptual frameworks. And with an overarching goal to create sustainable NPHIs that can build global health, public health capacity, achieve global health security, and increase public health impact. And really broadly, these functions are often measured by the JEE. So we wanted to deliver organization strengthen interventions. The way we wanted to do this was to be able to create a suite of tools that can be easily applied by NPHI leaders. Now, if any of you are familiar with lean processing, lean healthcare, Six Sigma, you may have heard of a terminology called sprint. Rebecca's smiling. So a sprint is a short, time-bound activity that is multi-stage, that is designed to create significant change through deep work. But it's time-bound, so you have to get it done within 6 weeks, 3 months, or 6 months. And then we wanted to apply these methods with NPHI partners, reflect on the tools, to be able to deliver a suite of tools that I would love to give to everybody in this room here today. The formative work we did was to actually speak to NPHI leaders. We did key informant interviews and focus group discussions with NPHI leaders from around the world, and they were led by my colleague who's in the audience, Anna Kalbarshak. We did a review of NPHI strategic plans. What was really telling was every single strategic plan was kind of the same, and I'll talk about that later. We also did a systematic review of existing tools, such as the stage development tool by IAMFI. What we took away from a lot of this was that there's a lot out there, But right now, the MPHIs that we were like talking to or working with, they weren't very mature. The majority of their work was reacting to problems, right? Their strategic and operational goals weren't well defined. They were sometimes even at odds with each other. And to really have growth and to really execute on your public health functions, you want an integrated approach, right? Towards the end, where those arrows are in synergy, moving to a common goal, common direction. And you know who does this really well? Industry does it well. Toyota does it well. Toshiba does it well. Microsoft does it well. The National Institute of Science and Technology created this framework, which is called the Baldrige Performance Excellence Framework. It's been around for decades. And what it does is really looks at these alignment of strategic goals and operational goals. Strategy in terms of the leader and the customers, and then operational in terms of workforce, finance, and then execution to shared outcomes. So we try to look at the Baldrige framework. We took all the lessons we learned, and this is the project framework that we created. So each of these blue boxes is a module that is fully available, that can be conducted in 6 weeks to 3 months, that is meant to shift an organization to execute on these activities. So the module at the base starts with the assessment and mapping of public health functions. And the reason why that was important is that without function, you don't have form, right? And so we really needed to know exactly what these MPHIs are responsible for, what was in their legal mandate, how do they coordinate, and also what are their pain points. Beyond that, in terms of leadership, we wanted to build the strategic planning and think about the partnership mapping. That moved on to workforce, financial diversification, and then for the future and really focusing on stability, strategic communications, and governance. What we also realized while doing all of these activities was that we would leave an NPHI and they'd have a great action plan. But the action plan is just a piece of paper that's put on a website unless we actually embed change management. So change management became this core module that is penetrated through all the other activities. So throughout the last 5 years, we've worked with Zambia, Sierra Leone, Liberia, the Republic of Georgia, and Burkina Faso, piloting various modules. And what I want to do is, for those of you who want to look at these modules, they're going to be freely available. But for some of you who are just here to listen, and there was a choice between the world is collapsing and maybe I could learn something, and you're in the I could learn something room, I thought I would try and give you some lessons to go home with, right? So for the modules we implemented, I'm just taking away a couple of learnings that for me are making me rethink about the world. And I'm going to end this talk with how this applies to our current state of play, right? So when we did a mapping and assessment of public health functions, we really wanted to use tools such as decision space analysis, process mapping, Fishbone, to really understand the root causes of some of the challenges that MPHIs were facing in terms of executing on their public health functions. So this is a process map looking at emergency preparedness and response in Sierra Leone. And what we really found that the pain points were around communication, folks not really understanding, when an incident management system comes into play, who are the roles, who are the decision makers, how is this funded, how is this financed? When we did the same process map for the lab team and the surveillance team, it was similar issues, right? Communication, coordination, decision space. And so using these process maps and then we talking through these pain points, we were able to use fishbone diagrams to really get to the root cause. And so this function mapping was a really great tool to get individuals to really sit down and understand their MPHI and the issues that they were facing. Strategic planning seemed like a really easy module to do, right? How hard is it? Write a mission, a vision, you have your essential public health functions, off you go. We tried to add into this some environmental scan. We conducted formative activities where we looked through the existing strategic plan. We tried to ask the MPHI leaders themselves to go through their strategic plan and then try and say, what have we achieved and what needs to go into the next strategic plan? And the strategic plan is a key document because it's a blueprint that guides all activities within an organization. Cyrus always says, form follows function, and then strategy drives form. So the strategy should be the underpinning activity that really guides an organization. And what we found was a little upsetting, actually. Many of the people that we spoke to during the strategic planning workshops didn't recognize their strategic plan. It had been written, it was on their website, it was downloadable, but it was written by a consultant, right? Not someone that lived in that country or executed those functions. There was no plan on how to execute the strategic plan. It was not costed, right? So it wasn't linked to the operational plan. If you remember earlier on, I talked about strategic goals and operation goals having complete alignment. But a strategic plan that's just a document without any costing doesn't allow for alignment. And it was too lofty, right? It was more of a vision than an actual action plan. The objectives weren't smart, they weren't time-bound, they weren't measurable. So this was a real important lesson for us. When we finished with our MPHI teams, our strategic plans went from 150 pages to 20. It went from big objectives to little objectives. And we actually were able to spend some time trying to cost out, especially the operational strategies that were embedded. And this was one of the big activities that we really focused on, was making sure the mission and the vision are aligned, the strategy led to the goals that were desired, and the tasks and the activities were able to fit with the objectives. And what we found when we were reviewing strategic plans with teams was there was a big mismatch between the means and the desired outputs. Partnership mapping was a module that we had the opportunity to lead in Zambia. And the way we did this was we wanted to actually map global health security partners. And we decided to do this in a workshop format. And we used a combination of tools. We used NetMap to be able to map the different partners. Then we had those partners come to stakeholder presentations and tell us about their organizations, their vision, their alignment. We then tried to really understand what the influence and investment of these partners were, and the goal was to develop a strategic communications plan. So during these activities, we worked really closely with the NPHI leaders. And at ZNPHI, the output of this was we actually assigned a strategic communications director, which ZNPHI did not have, because we realized that partnership strategy was much more complex than first anticipated. So these were the types of maps we developed. Each function, so each EPR, lab, workforce, had one of these maps. At the end of like 1 hour, we had over 100 partners. And then we had each of the NPHI leaders come and try and like put these partners onto a big wall. And at the y-axis is what is the investment of these partners, and the x-axis is what is the influence of these partners. And what we found was in the top right, I mean, those partners are high investment, high influence. Each of them needed their own like brand ambassador. Because what was currently happening was like for CDC Zambia, every single person in the organization was speaking to one person at CDC, but everybody was not singing from the same hymn sheet. So they really couldn't tell us like what they thought ZNPHI's priorities were. So we decided that, you know, a brand ambassador approach would be the best. We actually have this at Hopkins. Dr. Peters can tell you, some of us are not allowed to talk to Michael Bloomberg. Only one person is. He was one of those people. But you know what I mean? Like if you have a very wealthy investor, you need to be able to manage them. The missed opportunity was the bottom half. So if you look on the bottom right, those have high influence. So without engaging those individuals, you cannot execute on your public health functions. You can't do the surveillance activities or the health promotion activities you wanted. And so our strategy for these individuals to build technical working groups to invite these individuals with influence to the table as shared decision makers. The last module I'm going to talk about is workforce strategy. You know, when many people think about workforce, especially in a meeting like this, what do we think about? Technical skills, training, PhDs, right? Lab skills, building workforce capacity. But with Cyrus and Sarah's health systems lens, we took a different approach to workforce. We tried to do a workforce analysis, a supply analysis, a demand analysis, and then try to create a gap analysis to understand what was going on. And our workforce situational analysis, really, in addition to looking at the number and the demographics of the individuals and their clinical or technical competencies, looked at the development process, their engagement, their satisfaction, and burnout. And what we saw was burnout was really, really high. And we all can agree that there's high turnover in organizations. So the team then went ahead. We do like our 4x4 graphs. It's a very good tool. And what they did was they tried to come up with solutions to improve workforce engagement. And what they found was a lot of stuff that was both feasible and important was around culture. So changing organizational culture, we found in our work with, this was Burkina Faso and Liberia NPHI, were the most important strategies to maintain the workforce and execute on public health functions. And I think a lot of you may have heard this, right? But culture eats strategy for breakfast. It's really easy to get a training grant or do a workshop, a capacity building grant. But maybe we need to think about how to shift culture in organizations. There's a couple more modules that are available. Financial diversification, that was some brilliant foreshadowing from the Johns Hopkins team. And then strategic communication as we try and get MPHIs to articulate their value, their credibility, so they can better engage with stakeholders. And then change management was a module that is embedded in all of these activities. So when MPHIs finish a sprint and complete their action plan or develop their strategy, we have a change management tool that allows you then enact that action plan. This was a wonderful learning experience for me. Again, you can write really good grants when you have oxygen, but more importantly, you can do really important work and create buy-in by applying these tools from outside of public health to public health. And so I've been doing a lot of praying, crying, dealing with my stages of grief in the last month. And recently I started thinking, what does this all mean to me as an individual? And I have come to the conclusion, I'll talk about this in my session tomorrow, that it's about strategic alignment, right? Organizations, big and small, have weathered storms. When Apple came out, Microsoft didn't stop working. Microsoft innovated, pivoted, and became bigger. And I think applying some of these organizational management principles, thinking about strategic alignment, making ourselves more resilient for the future, is a really good way to weather this storm, because we're not going to stop doing public health and we're not going to stop doing global health. So I'm hoping that some of you be willing to take some of these tools, use them at your organizations, and really use the opportunity to reflect and become stronger for the future. And in case you're wondering on what skills you need to do that, I'm going to hand over to my next speaker.
And now some insights into how universities can help develop some of these.
Yes. I believe we have heard a lot about public health systems, the organizations, and I believe what is left is who will be doing all that. And the workforce, I will be mainly focusing on the Doctor of Public Health training as a way to kind of bridge policy and practice. I am a recent DRPH graduate, and I will be talking more about my experience as well. So we have heard again and again, public health systems are structurally very diverse, going from region to region, countries to country, and across these organizations, it is difficult to find a well-defined structure. And those who have a well-defined structure, they also tend to be very complex. And in this manner, it requires going beyond service delivery because there is a lot of policy formulation, there is governance, there is surveillance, there is advisory. As in Peter's talk, we heard lots of core public health system functions that we need to apply. But the challenge is we do have lots of lack of clarity in defining which institution and professionals should take on these functions, who should lead them or who should regulate them, who should oversee them. And I believe DRPH training in principle aim to prepare professionals to work at these intersections. These intersections mean policy and also implementation, and also having an advisory function where the role and contribution need to be critically examined in different contexts. So when we look how public health training align with health system needs, we do have different level of trainings that we might, there was a time we were trying to define what public health professional is. Whoever that we define to include in public health professionals, there is a need beyond technical trainings, and most of our professionals are trained on technical skills. Especially public health needs a significant deal of leadership. As it has been said before, being one of the most complex system, public health system requires a significant deal of leadership skill. And also there is a lot of advisory beyond doing. There is advisory, there is a study. And most of those studies can be done by very technically trained professionals, but communicating that so that it translates into policy is also another challenge. And this cannot be just done by researchers and implementers, and most of our workforce are researchers or implementers. So the current gap in public health system, especially in low middle income country, is as I said before, there is a lack of a structured leadership pathway in public health. And there is also role and mandates are often fragmented. So as it has been described, it's not, the pathway is not clear, and it's not also well structured. So this has led to lots of inefficiency in response and policy coordination, which we have experienced through the pandemic at a great deal. And DRPH training by principle and also by the program, the way it's designed, focus on these core, 4 core areas. The first core area is policy and system thinking, especially how to navigate the complex public health system. How do we feel that function of intersectoral engagement? One of the core functions in the WHO, we just heard this is one of them, is intersectoral collaboration and pooling resource for public health interventions. The second core area of focus for DRPH is also implementation science. And there is a lot of evidence generation out there by very technically trained, highly capable professionals, but translating that into something that is actionable and also scaling it with innovation effectively is one of the challenge where a DRPH training could focus, and the training is designed that way. The third is the leadership and governance. So in public health systems, leadership is a key, and especially engaging all the stakeholders that those graphs we have been seeing in public pandemic response or whatever setting of response, there are plenty of stakeholders, and sometimes the stakeholders are widely defined, but even if we put them in narrow definitions, there are lots of stakeholders to be engaged, and that requires meticulous leadership skills. And most of our technical training or programs will not prepare our workforce for that, and there is also a big deal of decision-making that goes. So the governance aspect of this program emphasizes around that. The fourth part is communication. So maybe I think one of the big lessons through the pandemic was controlling the narration and communicating to the public. How do we communicate what we have, maybe with lots of jargons, but the public want to know a message that's transmitted to them clearly. And also communication even internally within the system, the health system, the public health system. There is a lot of science that has to be translated for policy decision making, and the decision makers might need something that is just straightforward, not necessarily with a lot of those scientific jargons. So translating that requires a skill, and communication and advocacy is one of the main focus. With this, there is an effort. I trained in Harvard, but I came from Ethiopia. If there was a DRPH program in Ethiopia, I don't think I will come to Boston and suffer with all the weather challenge I faced. So there is an effort now going on to establish a DRPH program in Ethiopia and other African countries as well. The question is why now? So there is a significant recognition that public health leaders need structured, practice-based training, rather than going for very highly skill-based training and coming to a position where they have to make a leadership decision, but they were not prepared for that. So there is a recognition for that, and lots of African countries, including my country, also are rethinking workforce strategies to meet evolving health system needs. There is a lots of evolving health needs that are emerging, and it requires a lots of change in strategy. And in Ethiopia specifically, the ministry is exploring how to institutionalize a DRPH program as part of a broader workforce development. And this includes training the leaders, like whether they are regional level, even national level leaders, and equipping them with those core skills we just talked about. So with this, there is lots of effort going on currently, and hopefully we will be successful in that, and that will have a future impact. That is going to strengthen the function of the National Public Health Institutes, and also having a DRPH graduates as advisors, decision makers, and also network of them across the continent, that will definitely strengthen our public health system. And when we tried to do this, early on, we are facing with lots of challenge. And some of the challenges are DRPH program is a very resource-intensive program because it requires lots of disciplines to come together, and that's not easy, which requires very practice-oriented training, field work, policy engagements. And many universities also have a very PhD-centered academic culture, and that's leading to a lots of challenge, such as limited faculty experience. We are starting as a new, and most of the faculties have been mentoring PhD students, and the way they approach is going to be the way they know. And that could create another trained individuals with high skill of research rather than the one we are looking for. And this also has created a difficulty, is creating a difficulty in balancing applied learning with traditional research expectations. And there is also a resistance to valuing policy work and leadership development as equivalent to having lots of publications and going through the academic ranking. So it is very challenging to change that right away. There is a resistance, and need for institutional adaptation is also there because of all these new concepts that we are going to integrate. There is also a career path and differentiation challenge, which I faced right after I graduate. It is unclear, especially in most of African countries, it's unclear which pathway a DRPH graduate should take. Even though the purpose a DRPH graduates train for is known, but the system might not be that ready to still absorb them, especially because many low-middle income countries still recruit MEPH or PhD holders for senior leadership roles. And ministries of health and global agencies lack explicit hiring track for DRPH-trained professionals, including licensing also is challenging. So the differentiation between these high-skilled professions or training programs has to be very focused, very well addressed, because we do have in Africa lots of MEPH programs already focusing on applied public health, and their difference from a DRPH is sometimes confusing. And also, always a challenge between defining what DRPH and PhD, how they differ as well. So this, I think, requires strong institutional recognition to ensure DRPH graduate can lead in policy, governance, and system strengthening so that they will be able to fulfill the functions in public health system we have been discussing so far. Thank you very much.
Well, thank you to our speakers, Hailu, Bhakti, Zabir, somewhere out there. We don't have a discussant with us today, but we do have almost 30 minutes, 25 minutes for discussion, so you all be the discussants. Comments, questions, the microphones are available, and you can pose them to individuals or to all of us. Please. Or have we shocked you into silence?
I'll break the ice.
Thanks,
coming from a much colder place that actually has ice. So I'm David Peters from York University in Toronto, and thank you for the presentations. That was very interesting, and hopefully will stimulate a lot of questions and discussion. I was wondering, following up on back to your presentation where you say form follows function, structure drives form, and culture eats strategy rather for breakfast or lunch is the way I learned it, but either way, it's a lot of eating. So if it all comes back to organizational culture, what have you learned about how do you build the kind of cultures that you would hope to get in order to achieve the ends, or to change culture, because in many cases it's about change. And then more broadly, and this is maybe to all of you, how does the culture of universities and academic training, and some of this was alluded to, how does that intersect with the goals of these public health organizations?
Yes, great. Bhakti, you want to go?
It's a very cheeky question when it's asked by one of your previous chairs. So I'm going to talk about culture not in terms of Johns Hopkins, but rather the National Public Health Institute. And what was really telling in all of these activities is we tried a couple of different models of implementation. We tried to do this remotely through Zoom calls. We tried to do it where representatives from different groups were sent in. But where it worked really well was when the leadership of the National Public Health Institute, i.e. the directors, the deputy directors, and the heads of the various departments participated. And participated really when we were doing the difficult thinking reflection work, where the leadership was listening and also voicing their frustrations, right? And so what I learned about in this process was that there was a need to have a safe space for transparency, for talking through problems, and then for co-creation of solutions. And then there was a need for those leaders to step back and assess for themselves what they were hearing from their deputies or the individuals that they delegated some of these responsibilities to. So culture, unfortunately, is top-driven, but also culture, fortunately, is top-driven, which means that I think like leaders, especially in times like this, we have a duty to maintain a culture that's even keel, that is transparent, where they're not competing with each other for resources. The example when we're talking about partnership strategy was this poor guy at CDC heard from everybody on WhatsApp, and everybody was trying to compete for their workforce versus EPR, right? And he wasn't seeing a cohesive conversation. And so part of culture is creating safety in that we can create a shared vision so we don't compete against each other. And I think that's true for NPHIs, but it can also be applied to big academic institutions as well, right? Where the opportunity is effective partnering and not in competition. I'll hand over.
Ailu, you want to take a crack at that one?
Yeah, perhaps from academics, I think the culture will also echo the not competing, and lots of academic settings will, of course, compete with other academic setting for resource, but especially building a relationship between academic settings and the national public health institutes or ministries of health, where they could feed each other in a way, because, as example, looking into Ethiopia, I think we train a lots of workforce, but we might not necessarily train the workforce for the system. Sometimes there is a mismatch that happens because of lag in strategy alignment, or perhaps there is this drive to produce a workforce just because another university is producing a workforce. If one of the academic settings started a program, it feels like sometimes it is kind of a competition to just start that program to feel they are at the same level because they are first-generation universities, there is second-generation universities. I think that has created a vacuum that has not filled at some area for some areas which has not been focused by the academic institutions, but a big need in the national public health institutions or overall health system. So I think that alignment could significantly help the system. So avoiding the culture of competition and also aligning those strategies, I think, very much helpful. And this should come from both sides. I don't think there is specifically, the academics usually wait for the government or the national public institution to come to them, but I believe the dialogues, the communication should start from both sides.
So, and I want to add a thought too, David. That was a very stimulating question, and I don't pretend to have an answer, but I do think we should explore this question of the culture of universities in comparison to the culture of public organizations that carry out key tasks on behalf of society. And I think it's going to be different in different culturally, historically different places, different even amongst different European and North American countries. I think there are differences in the culture of these organizations, universities and, say, government and public health organizations. And then we have to ask the question, I think, for lower and middle income countries as well, where limited resources are being used to create universities. what function are these universities performing socially, right? And are they delivering for the citizens that are supporting them, right? Because we do have in many low and middle income countries large systems of public universities, right? We do have them here in US states as well. We don't really have federally funded universities in the United States as the federal government funds universities, but they're not federal institutions for the most part. So these are interesting questions we need to look into in a little more depth. So I guess we'll go to the other side first, and then we'll come back over here. Please.
Thank you. Adam Levine from Brown University. So this is for Bhakti and anyone else on the panel. You spoke quite a bit about, the benefits of national public health institutes, and certainly the desire to organize and centralize some of these functions makes a lot of sense from an effectiveness and cost-effectiveness standpoint. But how does that square or align with the greater sort of movement around localization and decentralization? It seems that a National Public Health Institute might be taking powers or decision-making away from local communities, which could be argued have a better ability to do it. And, that has equity implications, but, as we're learning now as well, it also has implications of putting all your eggs in one basket, especially as we look at our CDC in the United States being gutted now, and perhaps our saving grace being the fact that we are so decentralized and so many public health functions are done by so many other agencies that aren't going to be directly affected.
Yes, thank you so much. It's an interesting question, and I think this is where the function mapping and understanding really what the limits of the National Public Health Institutes are, and how they need to, in that partnership mapping activity, if you looked at those yellow boxes on the bottom left, they were really regional or state level organizations, right, that had to then execute. So I think the goal for the NPHI is the political stability, kind of the institutional knowledge, the ability to apply evidence-based, data-driven surveillance knowledge to health promotion, health response. But I don't think, and maybe even maintain, right, central training capacity. But it's difficult to completely decentralize a response that does always need to be coordinated. So I do think the way to think about NPHIs is like a hub that works with spokes but does not replace them.
Okay, great, thank you. I think we'll give time for other questions. So
I have 3 questions.
3 even.
John, I'm going to ask you just to put my last slide up. So I do want people to use the tools and download them and take them home with you.
Go ahead.
So for Bhakti, 2 questions. One is, how does that National Public Health Institutes, interact with the private sector, like in countries like India, where we have 60% of care in private sector? What is their regulatory role or governance role? How do they interact? And second, for a country like India, if you have to change anything, then you need a cabinet approval and a funding allocation. If you can tell us if you could achieve those policy changes and funding allocation. That's the first one. The second one for DRPHs, what I saw was missing was the clinical standards and quality. So because you had all the functions, but during COVID, we did experience that we didn't have an associations or organizations because our Minister of Health was not geared towards issuing clinical standards. Then we have to go back to specialized hospitals. So if you can focus on what is their role, or what is their role? If you want to take them an advisory role in Ministry of Health, then who will be responsible for assuring clinical standards? I think that was missing in your standards. The last question for you, Peter, because you have worked in India. In India, Indian administrative officers are the ones who take decisions. They are the ones who come to outside to do their MPH and come back as health secretaries for us. So, but many times, if we offer these courses within India, they may not consider them prestigious or valuable. But do you have any insights on what do we do? Who do we offer DRPH to? Indian administrative officers or the medical officers who are in government service or outside? I think I would like to hear from you. Thank you.
Well, India does have a unique issue in the sense that the the decision-making roles in government departments are run by a national civil service, which in a sense prides itself on shifting responsibility for individuals from one department to another during their career. I do think that this does make it more difficult to develop this kind of expertise, but senior administrators can take advice from trusted advisors, so we still need to have that capacity built up in these organizations. But the trusted advisors need to be skillful at giving that advice and understanding the structures in which they work to give that advice. I do think the experience that's under consideration right now in Ethiopia, where senior officers of government might see the DRPH, a locally driven DRPH, as a qualification needed for career advancement, so that they would be trained in their own country, in the structures of their own country, and this would be something that would be not necessarily the only thing they would have to do, but it would help them in getting promoted or advanced in their career. I think that's a good model for other countries to think about. So
I'll tackle the public-private partnership question, and I think the answer is the same as the answer I gave to Adam. Again, when we were doing any of these activities, whether it be function mapping or decision space analysis, private sector has a key role. There's also key investments that private sector can make in terms of innovation. They're not restricted by the same government mechanisms. So in the work that we did with the NPHI leaders, in the strategic planning, in the partnership communication strategy, private sector was a key stakeholder with whom to engage, and building private sector partnerships was a strategy that NPHI has identified as a way to strengthen surveillance and laboratory capacity. So I think, private and public health facilities are a part of the bigger public health system. I think the NPHI's role is much more smaller and focused, which is really on some of these essential public health functions, and again, using evidence to guide a nationwide response.
Hilo, you want to add anything? Or?
Yes, thank you for raising that. One of the concentration in DRPH could be clinical focused activities like the quality improvement, patient safety related activities. DRPH trainees could help especially map and put it in a framework rather than, of course, not directly engaging in the continuous quality improvement projects. Lots of clinicians do those, but overall at national or at regional level, even like here in US and chains of hospitals, DRPH trainees significantly help in designing those. Having an approach where it's innovative, entrepreneurial sometimes, is something that can DRPH trainees engaged in, especially when also they have a background with clinical, coming from a nursing, coming from a medical background. There is a tendency to focus on those, and I did focus on that area, and yes, definitely that's where they could help us well. Thank you for that.
Okay, thank you.
Thank you to the panel. I enjoyed the session. I have had about, must be close to 40 years in public health, although maybe I don't look that old. And I think I've learned that public health is a high-value, low-paid specialty. And that's one of our problems in public health, and people don't understand it very well. Most doctors don't understand it very well. Most nurses don't understand it very well. So if you don't understand something, it's hard to empathize and invest and so on. My most recent paid job was the head of the Caribbean Public Health Agency, CARFA, which was a regional agency covering 20 small countries. And I've had the privilege of working and training in the UK, the British National Health Service, I also did EIS, Epidemic Intelligence Service, here in the US, and working quite a bit in the Caribbean and Latin America. So it's some reflections on the public health has also evolved over time and how people perceive it. I think one of the big changes is how the environment's changing with climate change, and that has really focused a lot more attention. Perhaps COVID was in some ways a symptom of all of that. Now I run an NGO called Earth Medic and Earth Nurse Foundation for Planetary Health. And I was interested in Bhakti's analysis of what's an institutional strengthening approach. The things you were dealing with were corporate, they weren't technical. It was planning, communications, governance, partnership, financing, HR. And I'm wondering to what extent you think that could be applied to non-governmental organizations, which I now head up. And I'm learning, NGOs are not well regarded or highly regarded, especially by government. In some places, they're hostile towards NGOs. So that's an interesting position to be in, to have a different kind of hat on. But that would be one of my questions, whether you think it could be applied to other kinds of organizations, that approach. Thank you.
So absolutely. So I run a WHO collaborating center, and I have a colleague in the audience here. I have a Center for Global Emergency Care, and then I actually get 50% of my LOE through an NGO, JPIGO, which is affiliated with Johns Hopkins. And one thing that has really startled me in this last month is the lack of consideration of solvency that many NGOs happened. There's one particular organization, which is the second most funded organization at USAID, who let its employees go on a Thursday because they had such little funds in the bank to even pay for salary on a Friday. On the other hand, I went to my husband, who works in a health system that's private, and I asked Aditya, I was like, have you asked your bosses, like, what's your solvency plan if something goes really bad? And he said 600 days. Our health system can provide services without payment for 600 days. And so I think we all have to think this way, right? If you want to be sustainable and independent, I think this methodology applies to my teeny tiny center, culture, eat strategy for breakfast, and some of the tools that I was taught whilst doing this work, I have applied to the people I work with, my mentees, my trainees, creating a culture of transparency. One rule in my center is I never hide the budget. If there's a grant going in, the budget is there, you know my salary, but you also know what effort I put in, and you can question that, right? It's led to so much better collaboration and lack of hurt feelings. So I think an organization doesn't have to be big to apply these tools. It can be teeny tiny, but I do think that these additional competencies and skills, they're not traditionally taught in medical school or in public health schools, are going to be the skills from corporate that are going to allow us to be resilient and sustainable.
Okay, I think we have time for one more comment or question. We stand between you and the reception that's going to start at 7 p.m., so please go ahead.
Hi, my name is Abane. I'm a grad student from the University of Maryland, and I actually worked for Hopkins for some time. My background is a nurse, and I do have a question about the DRPH. Right now, I'm currently getting my PhD, but my first degree was public health. I got my first degree at the University of Rochester, and I really, like he said, it wasn't clear. I wanted to do so much in the public health arena, and I didn't know exactly how to get to what I was trying to do. I was working on a community health research, and the PI, she's a nurse, RN PhD, and she said, go back and get your clinical background in nursing, whether it's nursing or go back and go to medical school. So they're pretty much kind of steering you towards a clinician-like occupation to do more in the public health arena. And so I'm just kind of wondering, because there's so many different competencies that you need to really be very effective, especially in leadership in the public health arena, how is our curriculum going to change? How are we really informing people that really want to be a part of the public health arena, but they're going down these other avenues. How do we kind of redirect them and say, hey, is it the DRPH? Should we go for that? Because, for instance, I don't know how to really advocate for myself in a political field. I don't really know. There's a lot of competencies that I don't know. I have leadership skills, but that's more in the health arena, clinician side. But it's like, how do I go forth and take all that I have and be really effective on that scale?
Yeah. Can I take a crack at this one? Yes. This is a very interesting question, and I think it is a question that has to do with our health systems in higher income countries, as well as in lower and middle income countries, as well as your personal avocation, what gives you, what you want to do, what you love to do, and so on. As a professor of public health, I often get asked this question: should I do a medical degree or should I do a degree in public health? I think the first answer to that question is, what do you love to do, right? There are, of course, some personal interest questions that are around this. But I do think what we're observing around the world today is that all health systems are struggling. They're struggling to meet the needs of their populations in terms of comprehensive clinical services with increasingly costly technologies and aging populations with multimorbidities and people living longer with multiple health conditions. And I think we're going to see, in the early part of the 20th century, we saw a big advantage in clinical medicine in all the things that it could accomplish for populations. I think we're going to see a bit of a shifting of the needle, that we're going to need to deal more with mitigating the future demand for expensive clinical care through population health interventions, and we may be on the cusp of a new boom, if you will, in population and public health. We may not pay public health professionals the way we pay brain surgeons, ever, or certainly not for a long time, but then it comes back to, what do you love to do? So, and I think for lower and middle income countries, this is also a critical challenge, because there is a huge need for clinical care, but there is a huge need for addressing population health as well, and have to find that balance. So good question. I wish you luck in coming up with your answer. Okay, thanks everybody. Let me thank our presenters. And please enjoy the reception, which starts in 12 minutes. As well for helping us.